Hello, everybody. We'll probably have some people wandering in, but we need to start on time in order to get through the amazing array of speakers we have today. I'm Siobhan Harpur, and this is a joint event for the Menzies Research Seminar Series with the Community of Practice that's facilitated by the Tasmanian Collaboration for Health Improvement. So I'm going to just tell you a little tiny bit about that before we have our first speaker. And I'd like to just, before I do that, acknowledge the Aboriginal peoples of Tasmania, Lutruwita and Muwinina, here where we're meeting today, the land, sea and sky country that's never been ceded, and thank them for their sovereignty and the privilege we have of working and living in this place. So a little bit about the Collaboration for Health Improvement. If you haven't heard about us, we're a formal partnership between the Department of Health, Primary Health TAS, Health Consumers TAS, and the University of Tasmania. And these are broadly the three areas that we work in. One, we're very focused on implementation end of research, translating evidence into practice, making real world change in health and community care. And we're looking for every opportunity for those sorts of research projects. Secondly, we support clinicians, researchers and consumers with capacity building and capability building, very much in line with this seminar today, community practice. And thirdly, we enable the connections between people, and it's one of the things we probably do very actively. And if you have the opportunity to take a look at our website and become a member, you'll see there's a huge wealth of resources on there now that are increasingly enabling those connections to be made. So there's a QR code there if you want to become a member, which is free. And our membership's going up exponentially at the moment, I have to say, because of the resources that are getting onto the website. So it gives me great pleasure, though. The reason we're here is to hear about some stories of impact. Impact, as many of you will know, is now so significantly part of our applications for funding, 40% weighting on an NHMRC application. And it's really valuable to hear from people who are actually in that amazingly positive place of their outcomes becoming impactful in the community. And we're going to start with Dr. Michelle Kilpatrick. I just need to look at my introduction to Michelle, so forgive me for looking down to do that. And Michelle is a Senior Research Project Officer for the Tasmanian Centre for Mental Health Services Innovation. So she's moved into the Department of Health, but still very much associated with the university. Her research is focused on health behaviours, including nutrition and physical activity, obesity, mental health, barriers and enablers to health promotion, intervention, service evaluations, and workforce capacity building. So over to you. Thank you, Michelle. Oh, I'll just flick through those two. Okay.
Thanks, Siobhan, and thanks for the opportunity to talk about the work that we've been doing today. Listening to my CV, I'm wondering if there's anything I haven't done at this stage. But anyway, a jack of all trades. So the story I'm going to tell you today, though, is about how we leveraged a small finding, or one of the more important outcomes actually, from a larger grant, and took a very small amount of money, a lot of goodwill, leveraged some local and national and international collaborations, and I would estimate roughly conservatively about $70,000 of in-kind. So this is a little bit of a different story. It's usually pilots that get bigger. This is taking something from a bigger project and then seeing what you can do with what you found in that. So the project that I was involved with at the Royal was one where I led it in collaboration with obstetricians and midwives. And the goal of that project was to look to see how we could better support the clinicians to support the women that they were working with and caring for around health behaviours. And so we all here know how important health behaviours are to the individual and community as well. But as part of this project, which had the luxury of being a longer project, I got to know quite well the clinicians, and it became really clear that they saw promoting health behaviour change as a really important and core part of their role, and yet they really struggled to do it in the time-pressured environments and clinical environments that they work in. And they often work in fragmented care models, so hardly ever have the opportunity to follow up with a woman over the course of her pregnancy. Often they would only maybe even meet with a woman once or twice during the course of her pregnancy. And I also heard really strongly that despite this being such an important part of what they did, hardly any of them had had any training around how to support behaviour change in an evidence-based way. Pardon me. So, as part of this larger project, we piloted some healthy conversation skills training. Now, this was an evidence-based training program that I'd read about in the literature, and I'd actually heard about through some professional networks. And I knew of one researcher in Australia who was working with this. And so I was able to approach her as being part of this network and convinced her, with my personality, cheese and gin, I suspect, to collaborate with us and come down and basically run the training for free as part of this research collaboration. And this training, just quickly, is like a communication style. So it's teaching clinicians and practitioners to ask questions in a different way so that they're getting a different kind of information. Listening more, it gives them an opportunity to reflect on their practice and then using those skills to support goal setting. And importantly, it's in 2, 3 minute, 5 minute conversations. So it's using the limited time that you have more effectively. And it's not commercially available. It was developed up by a multidisciplinary team of researchers in the UK. And the way we can get access to it is through a train the model. So we ran this to maybe 20 midwives, 1 obstetrician, and a couple of other blow-ins from child and family health and physiotherapy. And the results, I mean, people were raving about it. So clinicians were saying they wish they'd had something like this 20 years ago in their clinical training. Everyone should have access to it, and it's completely changed the way that they do things. So emboldened by that, we sought some additional funding. So that's where we, with the support of TCHI, actually, applied for a $10,000 grant. It's got a mind of its own. So we'll just go back. $10,000 grant and built that collaboration. So it was with local clinicians and researchers, with Dr. Jenna Hollis from New South Wales, and then also to the UK. And the goal of this very small grant was to look at how effective the training is. Are people more confident and skilled at the end of it? But importantly, how feasible it is to scale this up into different settings and different locations across Tasmania, and what factors help make that a sustainable thing to do. So a very quick summary of the project and my possessed slides is, first of all, you have to be taught the skills. So this happens in 2 half days, typically. You get the content in the first day, then you get to go away for a week and practice it, and then come back and consolidate those skills. So what was really important to us was that we wanted to make this accessible, not just in Hobart. So we ran some sessions up in Launceston, and we put out an expression of interest, and we were at capacity. And what we did was targeted maternity services and then just went more broadly. And as you can see here, we tapped into quite a bit of interest without any advertising, really. It was just word of mouth. We ran the training in May. Again, it was free for participants. And the project costs subsidised Jenna's travel and accommodation. That was pretty much it. The rest was TCHI helping us out with rooms and things like that. And people, again, loved the training, and pre and post evaluation shows that they were more confident and skilled at the end of it. And importantly, 100% of them believe that their colleagues would benefit from the training. So the next stage of this is to teach those trainers, those people, to learn how to teach the skills to others. So again, it was an expression of interest to the then 75 people, I suppose, who'd learnt the skills. And again, we're at capacity. So we ran some trainer sessions, either one-day trainer sessions, and that's where they learnt how to teach the skills to either students or colleagues, peers. And again, they were satisfied with the training and very intent on going out and delivering it, and all felt that they had the skills at the end of that to do that. I should mention here too that not only did we have Jenna at this point fly down again and deliver the training for free, but her collaborator from the UK basically funded herself to come over and deliver the training for free. And she's been doing it in South Africa and China and India and all sorts of places. So the lure of cheese and wine is great. That's not my take home from today's talk. And so at the end of this, what we have now is this network of people capable of delivering these skills, which we know to be effective and people are wanting them, across a wide range of Tasmania. And I'm particularly proud of the fact that we've really got north and northwest, and there's already been some training happen there. And our local network of trainers now joins a growing network of international trainers as well too, including Singapore is now a star, and that's one of our newly trained trainers, Mary-Louise, who went over to Singapore to deliver the training there too. So next steps are, there is some research ongoing to understand what are the factors that will help these new trainers to embed this into their settings, including how to chunk up the content and things like that. Excitingly, it's going to be introduced into allied health curricula, most likely, and we've set up a community of practice as well too. So thinking about the potential impact, so we've got this training, this capacity building that came from, I guess, the luxury of coming from a longer, more established project where we really established the needs, we established the interest, but then we've been able to take it just with a little bit more money and energy. And we know that the people who've done the training are reporting that they're able to change immediately the way that they practice. And that importantly, it complements other evidence-based practices like motivational interviewing. So people have been saying it's doing the person-centered. We're told to do person-centered care, but I don't know what that looks like. Now we kind of know what it looks like. And we've also, with this small grant, been able to increase the capacity across the state, and that's now going into professional development, graduate training, and UTAS allied health. So just to finish up, I've hooned through, bearing in mind that the trainers only got trained up in November, mid-November last year. So by February this year, they've already gone out and run some training, some in community, some in clinical settings. So there's already around 40 health practitioners who've been taught the skills across Tassie. I mentioned that there's already a collaboration that's come out of it in Singapore, where they're looking to embed the skills training into a project to improve recovery after stroke. And this is one that I'm quite excited about. It's been embedded now into midwifery and nursing graduate training at the Royal. And so this is going to be something that's ongoing, and it's training up potentially about 120 graduate nurses and midwives in this sort of foundational skill before they get sent out into the world. And I mentioned also allied health are looking to get it into their coursework as well. So thinking about impact, we've been able to, as I said, take the most promising thing from a large project, and then with a lot of determination, collaboration, networking, and the goodwill of the practitioners is being driven by them now. My life would be easier if they didn't like it as much, if I'm completely honest. But anyway, if anyone would like any more information, please get in touch. Thank you.
Thanks, Ingrid. Thanks so much, Michelle. It's a very, it's a really great story of how something small can make such an incredible difference to so many people already. We're going to take questions for all three presenters at the end. So keep in mind what you might want to ask Michelle. I'm now going to introduce Associate Professor Dawn Aitken, who's going to give us our second story of impact. Dawn's head of musculoskeletal health and disease research group at the Menzies Institute. I'm sure many of you know her. She leads the programme of research on improving our understanding and management of osteoarthritis, which is known as IMPACT-TAS, which is about improving access to high-value care for osteoarthritis in Tasmania. Her work's been used to develop new physical activity guidelines for people with chronic diseases by the US Department of Health and Human Service, and she's contributed to Australian policy white papers. And Dawn also leads and collaborates on a number of major clinical drug trials aimed at slowing down or halting the trajectory of osteoarthritis. Thanks, Dawn.
Thanks very much, Siobhan, and thank you to TCHI for the invitation to speak here today and give a story of impact. So as Siobhan said, I'm going to be talking about a project today called IMPACT-TAS. IMPACT-TAS is a Tasmanian-based partnership project, and you can see all the listed partners and invested stakeholders in this work on the first slide. Now, before I can tell you about the impact that this project's having, I think it's quite important to understand the problem. And like many of the conditions that we all research, there's a major evidence practice gap in osteoarthritis care. So, for example, exercise is the most effective treatment for osteoarthritis. We have compelling evidence of its effectiveness and cost effectiveness. And it's recommended in every international clinical guideline. But in Australia and in many other places around the world, we have underuse of first-line treatments and overuse of medications and surgery to treat osteoarthritis. And a paper that was published in 2021 by Kim Bennell's group showed that when a patient presents to a GP with knee or hip osteoarthritis, they're more likely to get a surgical referral than a referral to a physiotherapist or an exercise physiologist. So we have the evidence supporting exercise, for example, and we have the guidelines supporting it as well, showing that first-line treatment for osteoarthritis patients should be education, exercise, and weight management where appropriate, and that surgical management should really only be considered for severe disease when all other conservative options have failed. But that's not what we see happening in clinical practice. This is important because, as I'm sure you know, we have an elective surgery crisis in Australia, and Tasmania actually has the longest public wait times for elective surgery in the country. And osteoarthritis is the main reason for hip and knee replacement surgeries. I'm sure you've all seen headlines like this. If you need elective surgery, it helps not to be Tasmanian. And these are constantly, you see headlines like this, and you see examples of patients who have been waiting years and years and years for a joint replacement. And when I see these stories, as a researcher and knowing the evidence, I start to ask myself some questions, like, have these people been offered first-line care? Have they been supported to try, for example, exercise? Can they access support for exercise? And unfortunately, the answer is no in a lot of the cases. So our collaborators from IMPACT-TAS have looked at people who are on the waiting list for joint replacement surgery. And what we see of those who are on the wait list at the Royal Hobart Hospital, 60% reported never trying exercise for the osteoarthritis. And at LGH, 11% of patients reported never trying strength training. So we're seeing patients being added to surgical wait lists and having surgery without being given the option of first-line treatment. So IMPACT-TAS is a collaboration that I formalized and established in 2021. And there's a lot of different sub-projects and aims of IMPACT-TAS, and one of them is to improve access to evidence-based care in Tasmania, and that's what I'm mostly going to be telling you about today. So We knew about a program called GLAD. I had seen it presented at numerous international osteoarthritis conferences around the world. It's an evidence-based education and exercise program for knee and hip osteoarthritis. It's delivered by physiotherapists, and just recently, GLAD's approved that the program can now be delivered by exercise physiologists, which is really excellent and will help it grow more. So it was developed in Denmark, so it stands for Good Life with Osteoarthritis from Denmark. And it's a 6-week group-based program where patients get tailored education and twice-a-week exercise. Why did we choose GLAD? It was just a really nice package that had all the evidence already there. So it had RCT evidence supporting its effectiveness, published in New England Journal of Medicine, to show it reduces pain, improves function, quality of life, and it even reduces your need for joint replacement surgery. So we were seeing that evidence, but then when it was being rolled out on a population level, there was real world effectiveness data. So it's been evaluated in Canada, Australia, Denmark, and it's implemented now in many other countries where it's showing to be quite clinically effective for patients. So we got in touch with the GLAD Australia team and asked them about the status of GLAD in Tasmania in 2021. And at the time, we found out that across Australia, there were over 500 GLAD providers already, and they were mostly in private physiotherapy practices. In Tasmania, there were 7 providers, and they were all in the private sector as well. So we said to GLAD Australia that we were interested in trying to upscale this program in a public setting. And we received a Royal Hobart Hospital Research Foundation project grant to partner with GLAD Australia and the THS to implement GLAD in the Royal Hobart Hospital outpatient clinics. And the research question that we were really asking ourselves is evaluating the feasibility of a GLAD program within a Tasmanian public healthcare setting. So the program's been running since 2022, and this is the flyer that THS put together to advertise the program, mostly within the THS and RHH, but it's also disseminated to local GPs now as well. So the program's running at 3 community outpatient clinics in Clarence, Kingston, and Glenorchy, taking referrals now from all clinicians, orthopedic surgeons, anyone who wants to, any clinician that wants to refer to the program. And importantly, it's free. So if you wanted to do the GLAD program in private, it would cost around $600 to $800, whereas THS is offering this high quality evidence-based program, and it's free to public patients. This was some media coverage that we got when the program was first started being offered in 2022. Michelle was one of the patients through in the first program, and you can see it. Marina is the physiotherapist who was leading that program. Marina was really instrumental in implementing GLAD and getting all the logistics in place so that the physio department could start offering the program. And in this article, Michelle, the patient, highlights that it wasn't long ago that she struggled to even walk a short distance. And she says, I cannot explain how much of a difference this has made in all of our lives. And she was referring to everyone in her group, in her GLAD class. So it was nice to get some media coverage, and Marina presented this at the THS Research Forum, where she won an oral presentation award, which was really excellent for her as a junior physio. So some of the considerations and logistics that we had to work through while we were setting this up, and I suppose were some of the ingredients for its success, was initially we had executive and RHH physio department buy-in and support. So Simon Watt, who's the head of the RHH physio department, meets with myself regularly and members of our musculoskeletal team, and had been interested in quite a while to implement GLAD. So he was on board, and he's very proactive around trying to encourage his clinicians to do research. So that was great that we had him, and then levels above him, so THS policymakers were also on board and happy for the program to be trialed in public settings. We had some champions within the Royal Hobart Hospital Physio Department, and that was Marina was one of them, but we also had 3 other GLAD trained physios who worked at the RHH and were able to accredited to deliver the program. So it helped to already have some people trained. And then the funding support that we got from the Royal Hobart Hospital Research Foundation and from TCHI and Menzies philanthropic funding as well, all helped to do the research project, but parts of the funding was really critical in first backfilling the clinical time for Marina to initially set the program up. So essentially we got the money from the Royal Hobart Hospital Research Foundation, and then we gave most of it back to the Royal, and that was to backfill Marina's position so that she could work with us to get the program up and running. And then we paid for 6 of the THS staff to do the GLAD Australia training, and GLAD Australia offered us a discount rate for the 6 physios. Then we had to work with them around which centres did they want to start offering this program in. And so there were 9 options in southern Tasmania that could accommodate group-based programs. And the centres that they chose in the end were high volume centres that had long waiting lists for osteoarthritis. It was strategic to put one on the Eastern Shore because they considered the bridge was a barrier for people driving from the Western and Eastern Shore. And that actually came out in some of our interviews with our patients, that they preferred to go to a Glenorchy site or a Kingston site rather than driving over the bridge to Clarence. We had to talk about rolling programs versus cohorts, and it had to suit the workload of the physios at each outpatient clinic. So they came to us and asked us and GLAD Australia, should we have a program where patients can come in every week? So new patients are, say, coming into existing groups, or do we run it as cohorts? And all the centers have kind of dabbled in a little bit of both and found something in the middle that works for their workload and staff, with the aim to run GLAD classes at their capacity, which is 6 to 8 patients. In the beginning, some of the classes ran with only 2 or 3 patients, and it became quite obvious to management and us as researchers that that's not a really efficient way to run the program, and that we really wanted them running at capacity to see as many osteoarthritis patients at one time, and that physio's time was being used efficiently as well. So as I said, it's now offered in Glenorchy, Rosny, and Kingston. We've had over 110 participants enrolled to date, and we're doing a process and outcome evaluation around the implementation. And one of the things that has come out quite clearly from our qualitative interviews is that most of the GLAD patients report that the program was effective to manage their symptoms. So this patient said it worked beautifully. After I started the program, it's sorted out, and they're talking about their pain, and I hardly ever have any pain anymore. The second patient I'm going to tell you about is a lady who came to one of our focus groups, and she lives on a really big block of land and enjoys that sort of rural lifestyle. She's out in the bush a lot on her ride-on mower, far from the house. And she said, this sounds silly, but I can actually do bush wheeze, which before was just really, really difficult. And that's actually really important for me because I'm out hither and yon. So we liked that quote. And I said, is that okay if I use this quote in public talk? She said, absolutely. Tell them I can do bush wheeze now. So she was a really nice lady. This person said, I'd made an appointment to go see the surgeon to see about the left knee. And then I went, no, don't need it. I'm going to put this off for as long as possible. And then we had some examples of patients who didn't benefit from the program. And that's always going to be the case. So this person said, I didn't find it actually alleviated any of the pain for me. And this patient had a lot of pain, and particularly multi-site pain. They had neck pain and back pain, and they weren't able to do the exercises without aggravating their neck or back. So in their mind, they said to fix one, I was hurting the other. And this lady was very persistent, and she still went to all the classes. She couldn't do the exercises, but she just walked around the room. And so, I mean, walking gently is probably not enough exercise to have that beneficial improvement, but it just highlights that there's going to be a subgroup of patients who are going to need more complex pain management than the GLAD program can offer. So we then wanted to develop a clear referral pathway now that the programs are running. In 2022, the focus was really just to become established. The physios said, don't tell anyone about it because we're just finding our feet. We don't want to be inundated with referrals. Let's just keep it within our department. We'll only take referrals from physios within our department. But once they started getting the ball rolling and feeling confident and they didn't feel inundated, the admin assistants felt like they could deal with all the sort of extra admin load that a GLAD program had. We started advertising it first to the Royal Hobart Hospital Orthopaedic Department. So we contacted heads of department and they disseminated within their clinician team, and then the Royal Hobart Hospital Rheumatology Department. So a lot of referrals now are coming through these three departments, but also through local GPs that have heard about it through word of mouth, and a little bit through our GP co-design study that we're running now, where we're going out and talking to GPs about the program. We worked with Department of Health and Primary Health Tasmania to establish an e-referral pathway. And that was really important because the e-referral system is being rolled out in all GP practices around Tassie, and THS really want us to use the GP system. So when we were talking to some of the surgeons, they said, I'd like a referral pad, a GLAD referral pad that I can just scribble on and give to the patient. But the THS didn't want that because they're trying to phase out referral pads and make it all electronic. So we worked with Department of Health and Primary Health Tasmania to get something that was available for THS staff, but local GPs as well. So if you go see your GP, you just have to open the HealthLink software. They all have this now. Just 3 steps. They have to click physiotherapy community, which is how they would refer a patient anyway to public physiotherapy. And then they have to indicate south. And in this box, they can, we weren't able to have a GLAD option at this stage because it's only available in 3 outpatient clinics. But when it expands more, there is opportunity for us to actually have a little GLAD box. But right now, they just have to write GLAD program and it will all be triaged by the physio department. So we're bringing these instructions out to GPs this year and advocating more for the program. And we've actually had the physio staff say, tell as many people about this program now, because the longer our wait list, the more they're going to expand this program to other outpatient clinics around. So now everyone really feels on board. They're not sort of on the fence like, oh, what's going to happen? Are we not going to be able to manage this? Or I feel like it's really just been quite a success. And very slowly but surely, IMPACT-TAS is changing clinical practice in Tassie, and it's really resulted in a beneficial change to health practice and increased health efficiency. So before GLAD was offered, if you got referred to a physio in the public, you'd probably wait 12 months for your initial physiotherapy appointment. But now, because they want the GLAD classes operating at capacity, people with hip and knee OA are being prioritized. They're getting put into a GLAD program, and the wait we have currently is about 1 to 3 months, which is really excellent for these patients. And we are expanding around the state. Since our team has been talking about GLAD program, I feel like in some ways I've been banging on about it for a long time, but I've done so many community talks and clinician talks, and it's increased the amount of private physiotherapy practices offering GLAD as well. So we've gone from 7 to 12 now, and we're working with THS Northwest to expand the program in the Northwest in a public setting. So I'll just finish with a statement from one of our consumers. Another thing we did last year was set up a Tasmanian-based GLAD consumer network. And this was a man that got in touch with us when we were trying to get funding for the expansion of GLAD in the public setting. He said, my name is Les Shear, and I'm a former GLAD participant who lives in Burnie, Tasmania. I was first introduced to the GLAD program when I presented to orthopedic surgeon for knee replacement surgery in Launceston. The orthopedic surgeon suggested I try the GLAD program before going ahead with the surgery, and identified a private physiotherapy practice in Devonport that I could attend. So Les was in a position to travel from Burnie to Devonport and pay out of pocket for the GLAD program. I completed the program and found it life-changing. I now enjoy 5 to 7 kilometer daily exercise and no longer feel that I will need a knee replacement. I'm very aware of the barriers to accessing physiotherapy, and I'm highly supportive of the IMPACT-TAS project, which is upscaling GLAD to more locations. So it was really nice to have Les so supportive, and he's really been part of our team, helping us with lots of grant applications and project management. So IMPACT-TAS is a big group of people, and it's a real team effort to keep taking small buckets of money and trying to do good things with it. And I'd just like to thank all the supporters for IMPACT-TAS as well, the funding support that we've gotten. Thank you.
Thanks so much, Dawn. Again, you know, I can think of lots of questions I want to ask, and so exciting as well to see that real world impact. One of the things I know I'm struck by is that when we are doing that pointy end of implementation, how much support is needed in those environments that we're working in, and that was very evident with both the two talks we've had so far about the need for giving some of the money you got from the Royal Foundation back into the Royal for their backfill of clinical staff. It's a challenge for the research field in translational research. So now it gives me great pleasure to introduce Professor Fay Johnston, and a very different part of public health work that Fay's involved in. She's a public health physician who I had great pleasure in working with in public health for many years, and an environmental epidemiologist who heads the environmental health research group at Menzies Institute for Medical Research. She's the director for the Centre for Safe Air, which is an NHMRC CRE. Fay co-leads the bushfires, air pollution and extreme events theme of the Healthy Environments and Lives Network. And she co-leads the air quality impact priority of the Sustainable Communities and Waste Hub of the National Environmental Health Science Programme. Her main research areas include bushfires, climate change, air quality and health, the health impacts of wood smoke and aeroallergens, and the interventions for protecting health from airborne hazards. So thanks very much, Fay.
Thank you. Thanks, Siobhan. Thanks, everyone. Thanks for inviting me here. My presentation is actually a bit more personal and reflective of sort of who I am and how I got here, because there's so many stories along the way, but there is a bit of a theme. So I thought I'd just reflect on that and what impact it is, and how some of my projects seem to have had impact, some don't, you know, and overall, how did we get here? And I began by thinking about what actually is impact, and it reminded me of this ancient old joke that most of you probably know, but I was, how many psychologists does it take to change a light bulb? And I actually think the first two presentations illustrated this beautifully, and I think most of you know the answer to that one. Only one, but the light bulb must really want to change. And when it's coming to impact, really, that's what we're trying to do. It might be individual behaviour with risk, it might be public health policy with all the machinery that goes with that, it might be clinical practice guidelines. At the end of the day, we're taking an entrenched sort of system that everyone's happy with, you know, like a ship in the ocean, and we're trying to get it to change course a little bit to align with the evidence, because that's our thing and we're across it and we know what that is. But we're just a puff of wind, and there's currents and waves and headwinds and things well beyond our control, like, you know, like politics, like funding, like all sorts of things, other players and other actors. So it's a bit daunting when you have to write these NHMRC impact stories, right? And they have to be so curated, and you have to explain how you, as this one little actor in this whole ecosystem, came to have impact, and why you're worth investing in even more. So I'm going to tell you two stories, and they're actually two versions of the same story, but it's a bit of a potted history of some of the projects I've been involved with, and, you know, and how they came to be. And story one is a bit more reflective of how you might have to write it to sell yourself. And story two is a bit more of the reality of my experience going through and sort of ending up where I am now. So story one goes a bit like this. It starts with the amazing research you did, and I was working in air quality and health. I was doing my PhD and I found all these amazing epi associations with slight increases in air pollution in communities. You know, obvious ones like increased ambulance call out for breathing difficulties, you know, but ones that surprised me, like increased ambulance call outs for hypoglycemic episodes in people with diabetes, and call outs for sudden out of hospital cardiac arrest, and a few other cardiovascular ones, some other projects that found associations with the gestational diabetes incidence in people who were pregnant when there was more pollution around. So there were all these outcomes well below, beyond the famous lung impacts that everyone associates with air pollution. And yet our guidelines in Australia were very shaky. They didn't include this. They would tell people who the risk groups were, but they left out, you know, when I began this, people with cardiovascular disease, certainly not people with diabetes, certainly not people who were pregnant. There was hostility to saying things to people who were pregnant because it might make them anxious and that's bad for them. But, you know, the paternalism of that kind of thinking instead of just sharing and educating and giving the evidence. So there was a lot of entrenched ways of doing air quality. It wasn't particularly well taught in clinical or public health training I did. But anyway, so that was where I began. And then, of course, I communicated it widely and I spoke to all sorts of people. I, you know, met with land managers about how to do planned burns more safely in terms of fogging people with smoke, you know, with people who built wood heaters, geriatric, you know, senior citizens groups, apart from colleagues in public health, you know, so there's all that work of communication. And then guidelines changed. It was great. So now we do have guidelines that include all the high risk groups. The advice they give is actually a little bit more in line with evidence. The levels we set to tell people when air quality is beyond background or might be risky for them is now more in line with the evidence. And then also knowing that, you know, this is with air pollution, the biggest impacts are the average yearly load, right? It's the everyday fluctuations. It's a bit like what you eat with diet with a whole lot of chronic disease risk factors. It's what you do every day that determines the risk from that hazard. Yet the paradigm in Australia, and it still is that it's a bit like panic about sugar intake at parties and not helping people with their everyday diet, right? So that's where this app that our team developed, Air Radar, came from. It was real-time information so people could know what's in the air, pollen or air pollution, and just self-manage, you know, because they had great evidence-informed guidelines and could take useful action to manage their health. So, you know, how you commute to work, for example, the timing or the way you go, it's an everyday exposure. That's going to influence your air quality and your health much more than whether you can dodge a planned burn or bushfire smoky day once a year or whatever. So we got this new service. We knew it was good because when Black Summer came, 50,000 people downloaded it all at once, and we were just working very hard to keep the servers going and keep the service. Because at that point, we were the only service providing real-time information about air quality, because the entrenched way of doing it was to tell the public what the air quality average had been over the previous 24 hours and give it a rating, and that didn't necessarily reflect what was going on right now. People would be told the air quality was good when it was terrible, and vice versa. So it was very confusing. So at the end of all that work, we've now got all these tools, evidence-based guidelines. We've got a healthier, informed community. We've got, you know, tools to navigate into uncertain environmental changes. So that's great, right? But it's kind of real and it's kind of not real. So I'll tell you story 2, which is a bit more reflective of this journey. And probably the first and most important one, it was the amazing collaborators I've had, both in my scientific teams and in my, I think what's really helps with IMPACT is the fact that I'm a practitioner. So you've already got two-way input into where the research might help, where the problems are in practice. But the same in research teams, particularly because I work in the environment. You kind of have to think about all clinical outcomes, so it's good. I've got medical training, but you also have to think about the environmental hazard you're studying, and that involves fire ecology and meteorology and, you know, all sorts of things. So you have to have the right collaborative team, and you've got to learn a lot along the way and just figure out the path where you can be most useful with your skills in that. So that kind of collaboration, I think, is fundamental. If there's one thing I want to acknowledge, it's kind of that. Then the communication step. It's iterative, right? Between but it's complicated and it's long, and it means me. And I did my PhD on bushfire smoke, and I got a poster at the Australian Fire Authorities Council meeting in Hobart. I didn't live in Hobart at that point, about planned burn smoke and how it sent people to hospital in great numbers, you know, wanting to go and interact and talk to the fireys about, you know, ways of mitigating, not stopping it, but just, you know, letting people know, you know, so they've got the opportunity to do things to protect themselves. And my partner, who works in fire and knows all these characters, and said, just be careful, they're going to want to hit you, you know. You know, they've got their way of doing things, they've done it for years. They don't want some little upstart coming and, you know, showing them a problem, which they didn't believe, genuinely didn't believe it was a problem. You know, smoke was natural, and you don't want your house burned down, do you, dear? You know, kind of response. So there's lots of examples of that. And I guess the lesson for me was seizing opportunities when they come. So you're quietly working away and sharing this. For me, the big opportunity really, which was a disaster for Australia, but the Black Summer bushfires, was finally when my public health colleagues and politicians and others sort of started thinking about air pollution. The response in my career has always been, oh, you don't, you know, that China and India and there's all these places with worse air quality, so we haven't got a problem. Regardless of whether the evidence is telling us we've got measurable population health impacts. We don't do that for health and education systems, benchmark ourselves to some of the, you know, most disadvantaged places in the world, but we kind of do with air. And I always find that interesting because it's one where we can have some quick public health wins. But anyway, Black Summer happened, and it sort of brought home that this is a new and increasing hazard. So there were royal commissions. There was great work Nico did on characterising impacts. I could present to the Royal Commission, I could talk on the radio, so that was an opportunity when people wanted to hear about my passion. So that was useful. I could give clear recommendations like, let's make real-time information available across Australia, not just through our little service. And that was agreed, that's been rolled out, you know, let's have categories and advice. That was agreed and implemented, but then it's all complicated because it's then handed to government agencies who don't have your level of expertise, who are under pressure from their ministers. So huge rush. We had these national categories and guidelines, and in my point of view, they were just all wrong. They were, you know, the bar to say the air wasn't good was set incredibly high. So we'd have all these fluctuations in air quality. People would be told the air quality is good, you don't need to do anything. And yet I knew that ambulances were peaking and people were going to hospital, missing school, all this impact at the public level that was disregarded by the group who set those. So patience, tenacity and a long-term view. Finally, I think this is now 4 years later. I'm just waiting for the final endorsement from AHPPC on the N-Health guidelines that I helped generate that actually brings it all back into line with evidence again. So I'm hoping we've got there on that one. But, you know, there's a lot. I guess you've also got to be a bit tough with this because just on that story, it was rushed through because there was another jurisdiction in Australia that had environment, not health, you know, and those two silos, even though environmental health needs communication, that doesn't happen particularly well in Australia. So there was someone working for their minister who wanted to get it through, who had a big department. They really didn't, they just wanted it through. They didn't want any challenges. They didn't want Tasmania saying, no, this doesn't work. You know, and then they were happy to also say, well, it's a bit unethical, isn't it, Fay, that Tasmania is not following these guidelines? You know, so there's a lot of pushback, I guess, because it's not suiting other vested interests. But I think we've got there on that one. And then with this great app, you know, it was great at the time. We get lots, and we still do, lots of incredible feedback from people who use it. After Black Summer, we were so busy trying to keep it alive on little short-term research grants for what essentially was, I mean, it was great research that came from it, but essentially it was a public health service as much as a research tool. You know, so we went to UTAS and said, help, and then there was all this advice, how can we make this sustainable? How can we get ongoing funding? Should it be an enterprise? Should we, you know, so there's this pressure to, you know, have impact and spin out companies and be a startup. And this seemed like a great one for UTAS to help us with. And we do have a new service, and we now do have an enterprise, but it's a really long and difficult road. And I don't want to sugarcoat that, really. It's a huge blow to your active research because it just puts you into roles you're not used to being in, which is entrepreneur and negotiator and deal closer and board member, and, you know, and problems come up and you have to deal with them. And we're in a stage, you know, called the Valley of Death. It's well known in startups. We're 6 months in, you know, and most enterprises fall over in that first year, right? So we're at a very delicate stage. Before I embarked on this, I actually spoke to another UTAS researcher who'd also commercialised something, you know, tourist tracker app. I don't know if you know the tourism. And she told me it was the best and the very worst experiences of her research career came from doing this. It was sort of like buyer beware. It can be great, it can be hell. And I'll have to say it's probably the same for me. I think the best might be yet to come if it starts flying, but I'm still kind of waiting for that. Then it will be amazing to have this service that's launched and running independent of me. But we're not there yet. So have we really changed the world to a healthier, more informed community with all these tools? And I guess my reflections at the end of that is, you know, maybe with all this effort and working around, we're probably a few steps closer to it. And maybe that's okay, because we can all do what we can do and work where we have influence. And it's a bit unrealistic to think that one puff of wind's going to change an ocean liner. So it's totally inspiring hearing those other two case studies where you see one puff of wind and then you see momentum build and it going on to having impact. I think it's hard to set out with the intent you're going to change the world. I think all of us can do is think about where we know we've got skills, where we can contribute the group, whether it be as a leader or a brilliant analyst or as a practitioner who understands research, and just do that bit really well, because it's kind of the critical mass you need with all people working together, in my view, that gets you there. So that was it from me. Thank you very much for listening. Yeah.